Welcome to Revive Health's Daily Briefing Live for Monday, May 4th. Our 30-minute review of the latest, most important news and resources and advice for health system marketers and communicators dealing with COVID-19. I'm Jeff Spear, Senior Strategist here at Revive Health, subbing in for Chris as host for the show, so we can turn the tables on him. Everybody's been waiting for this moment. I'm joined by Jaleesa, Marketing Specialist at Revive Health, and our show producer. Hey, Jaleesa.
Hello.
How are you?
Doing good. Thank you.
Great. As I mentioned, we'll turn the tables on Chris today. Chris, the regular host of the show, but today we're going to ask him a lot of questions. And most of these questions are from the street, things that he's been hearing. A lot of clients or others have been peppering him and the rest of the firm. So just a quick background, as most of you know, he's a longtime health system marketer and thought leader in the space. He's written 6 books, including the Joe Public Doesn't Care About Your Hospital series, and a frequent keynote speaker at many conferences, and worked with many health systems across the country in marketing and branding. Chris, thanks for joining us.
Thanks for having me. This is weird.
I've been looking forward to doing this for a while. So, yeah,
okay.
Get excited.
All right.
Real quick, get some out of the way. As with each show, we plan on covering the latest news on COVID-19 and how it relates to marketing communications. We're going to share what we've been hearing from Marcom professionals across the industry. As we move through the show, please use the question queue in Zoom to line up your questions. We'll get to as many as we can at the end. You can also use the chat function to talk to each other, but if you have a question for Chris, I, or Jaleesa, please put that in the Q&A queue button. Also, you can subscribe on the podcast, to the podcast on iTunes. Search for Revive Health Daily Brief Live. We'll be posting a recording of this episode by today. You can also visit our website, thinkrevivehealth.com/COVID-19. And there's a bunch of other content up there related to the crisis as well. Consumer survey research, previous podcast, and always good to look at that. Since we've covered so much ground in the past, I think this is probably like show 40 something. I think we've covered pretty much angle.
Getting there.
Yeah, right. So it's always good to look back if you miss some, and you maybe see some topics that you're encountering now that may be more relevant. So a couple other important notes. We're not experts on COVID-19, so this is not a place to come for medical or scientific advice. We will share opinions from marketers and communicators on how you might want to manage the crisis, but everyone's situation is unique, and in the end, you have to make the decisions that are best for you. Okay, let's begin. We always start the show with the layout, and we use the Johns Hopkins tool. And as of right now, there are 3.5 million total confirmed cases in the world, and that's 1,161,805 in the United States. And that has risen to 67,913 deaths. So we're nearly at 70,000. And I believe on Friday we were maybe around 60 or 61,000. Mm-hmm. It's, they've got a scale, and a logarithmic scale, and it's still headed, it's not headed down or really flat.
No, I think we're approaching, so we've often kind of talked about the comparison to the flu, which is, I hope by now nobody's still saying, but I think some people still do. We far surpassed the death count of the flu from the last full flu season, 18 and 19, I think it was, which is in the low 30s. I think the big one, though, is one prior, 17, 18, which I believe is low 70s. Chase had this somewhere, Julie, so I won't put you on the spot to find it, but people can look it up. I think it was like 70, 71, 72,000, which was huge. And so we're going to pass that. And again, that's a 8-month. Right. The seasonal flu is an 8-month season, and we're still in month 3 of this. So, well, from what we know, month 3. Anyway, sorry.
Oh, okay. Yeah, you're not the host. I am.
I know. I'm sorry.
Let's be careful here. All right. Let's get in a couple news articles. On Friday, Stat ran a very long but good article talking about 3 potential futures for COVID-19, and the descriptions will tell you a lot. Recurring small outbreaks, a monster wave, or a persistent crisis. There was one line that I thought, kind of riding off what Chris just said, that I thought was extremely poignant. It said, quote, "The experts told us while the new coronavirus might settle down and simply cause colds," and this is way in the future, may cause colds like the other 4 human coronavirus already in circulation, it was more likely to return year after year, like seasonal flu, causing illness much more serious than sniffles. But there's a lot more behind that article. Chris, you read the article. What are some of the things that stood out to you?
Well, it's just statements like that. So it cites a lot of, well-known institutions, Johns Hopkins. It cites a guy from my neck of the woods, Michael Osterholm, who's from University of Minnesota. He's been out as an epidemiologist a lot. One of the statements in there is from, I'll get his name wrong, it's Amesh Adhala, I think is how you pronounce it, of the Johns Hopkins University Center for Health Security. He said, October 2020 will look nothing like October 2019. And then Michael Osterholm comes in and says, and neither will October 2021. So essentially there's kind of 1 out of 3 of these that feels okay. The recurring small outbreaks. But another monster wave, which we hope we're not actually incenting with our reopenings. Hopefully that's not the case. Or a persistent crisis. Neither one of those sound really good. There's just, the story goes into a lot. So I think it's worth a read for anybody in this industry.
Yeah, it does. I think we're all living in these weird realities where no matter what state you're in, people are thinking about reopening and feeling like, okay, we're almost there, we're almost normal. But you also know that it's not going to ever be normal. And I think that causes a lot of difficulty for people that are planning businesses, and what they need to be doing, including our friends in the hospitals. So speaking of reopening, Nebraska, Alaska, and Florida are opening for elective procedures this week. And that kind of goes straight into one of our first questions for Chris as we transition. Whether it's in Nebraska, Alaska, or Florida, does Joe Public care now?
So you got to get there out of the way right away, huh?
Just do it.
So this has come up a few times on the podcast, and I think it's a totally fair thing to throw out there, right? So Joe Public doesn't care about your hospitals based on the premise that the vast majority of people do not care about hospitals or health systems the vast majority of the time because they don't need those services, right? Obviously, we have hit enough times on this podcast how that is different in this pandemic. So our research has shown time and time again that people want to hear from hospitals and health systems on a repeated basis. There's a need that we need to fill, both from a health information standpoint, but even from a maybe higher level leadership standpoint in this country. So yeah, Joe Public cares now. I think the question is, how long will that be true? And obviously, given the last story, hopefully that's not true for an extended period because we continue to deal with this at a significant level. But even beyond that, I think, and maybe we'll talk about this later, there's a potential that the role that hospitals and health systems play and the perceived role in our society changes. And that may get us to a point where people do start thinking about us and caring about us on a much more frequent basis, particularly as we think about like health, right? So we talk a lot about health brands. And that's an uphill battle. We've always said it has been to be able to shift to be seen in that light, but maybe now that's going to be easier, which gets us there.
I feel like if there's anything we're learning right now is that the consumer is a fickle person, and what they will support or won't support is can be changed, but sometimes it takes something really massive to do it. But at this point, I think the question, or what you said, was for how long can we get them to care? But I feel like the potential is there to get them to see the vital role of health systems and health, not just in acute is happening, but something long-term. The resources and the connection in public health and health systems in a community level state have been depleted for years. And now we can see that it is devastating to all of us when that happens.
Yeah. I mean, it's kind of weird because as hospital and health system leaders and marketing leaders, you want Joe Public to think about you. Like, that's what we crave as a brand. I mean, we've got a lot of advantages when it comes to branding because we actually do something that has real meaning for people's lives. We always have, right? I mean, it's different than like we joke, would you rather be the brand manager at Oreo cookie? And you're like, is it regular or double stuff today? Like that's the world you play in. That's a very different world than we play in. But on the other hand, do we want what does it say about the world we live in if we are in a state where people have to think about and need hospitals and health systems every single day? Like, we don't want, like, nobody's happy with that now for the reason for it, because it's a pandemic, right? And so that's the balance, is can we move away from the critical healthcare crisis that is causing it, but still maintain that sentiment? That'll be the deal.
Okay. Second question. What should a health system be focused on communicating right now, today?
So should I pretend like I haven't seen some of these questions?
Yes.
I've seen some of these, but I didn't know, like Jeff's going to throw some curveballs at me. I know they're coming. So obviously the answer to that depends on where you're at, right? A hospital in New York is different than a hospital in Cincinnati versus a hospital in whatever, Las Vegas. And we've been saying that all along. But I think if we want to look at the context of the idea that we are reopening. So we started that, the podcast talking about 3 states reopening now. In terms of elective procedures, we've had other states already there. Pennsylvania's there, Ohio's there, Oklahoma's there to varying degrees. That is probably the number one focus now, even though all of these health systems should still be communicating about COVID-19 information and awareness still. Right. They are now should be planning for and or communicating about reopening. What I will say though is, so that's where you should be focusing. What should you be communicating? There's a lot of stuff we can get into, but I think what we're seeing now. So I think we've been reopening for maybe 2 weeks, tops, from the first state, like Ohio. I think Ohio and Oklahoma were maybe the first states. I could have had that wrong, but it's not been long. And what we're seeing from a lot of systems and even clients is this rush to get to market with some kind of high level "we're open" message, which is understandable. Because you want to let people know that it's okay to come back, that there's, important health issues they need to deal with. And B, like we've been talking about, hospitals and health systems have been taking it on the chin financially. So we got to get these people back in because we're losing millions of dollars every week. That said, it is not as simple as just a message out in the market. The example I use with folks is, this is super simple, but I think it helped paint the picture, because we're talking with people about everything from internal communications to patient communications to external, opportunities. If you go out to market with any kind of message that says we're open. So first of all, most health systems are not just flipping a switch. So again, this is not my quote. Somebody else said it, and I'll give them credit anonymously. Nobody's flipping a light switch on. They're using a dimmer. Yeah, you're coming on gradually, right? And not only just across the organization, but over time. So you have to be careful in saying we're open, because are you open? Where are you open? Is it universally so? If somebody sees that message, are they going to think that you're open over here and then not be able to get in? But second of all, from our perspective, you had better have had contacted every single patient that was either canceled or postponed before they see an ad in the market that says we're open. Now, that seems like a huge lift, but when you think about it, if you're a patient, and I can give an example of myself, I just got a call on Friday. It was not well handled, but at least I got a call saying, hey, your procedure on May 11th, we've had to cancel it because we're still not able to see you. If you want to reschedule, great. If you want to do virtual visit, which won't work for what I need to do, great. It was a minimum, like they need to do better, but at least they told me. Imagine if I had seen a print ad or a billboard if I was driving around, or a display ad online that said, hey, XYZ hospital now open for procedures. And I was like, A, they hadn't contacted me. So does that mean I'm cool? And then B, I'd gotten that message saying, actually, no, we're not, despite this out here. And so we're desperately trying to tell people, look, it isn't that simple. We really need to be smart about this. It needs to be nuanced. You got to think about your current patients, the ones that have been put off first. Just allow for all of that. Even if you are going out, you have to allow for those nuances.
And it puts marketers and communicators in a tough spot because most have been under-resourced as it is. They may not have the right CRM tool, for example, to make some of this easy. Their connections to operations aren't always good. And maybe some of their teams are taking time off right now or furloughed. So it's a lot to handle.
All on top of, so you have, let's talk about supply and demand. Let's put it in those terms. You have maybe the lowest level / most restricted supply in terms of marketing capability, to your point, right? Furloughs, budget cuts, right? To whatever degree. Now you have from internally, perhaps the loudest cry for demand of marketing that we've ever experienced. We all know what that's like being in this business of having the squeaky wheel demand advertising, right? Like my volumes are down. So the problem must be nobody knows about it. So let's get the story out there about my toe jam surgery. That has just always been around. Now we have almost all the physicians, all of the service lines in an organization clamoring, demanding, even though they're not even ready in many cases to see patients. And so that's, to your point, a really tough place to live, where you're limited in what you can do and you're getting more loud pushback to do something. Boy, it's going to be hard to really try to do the right thing.
So here's the curveball question. We're talking to several health systems right now that are reopening and figuring out their operations. What have you seen operationally that has surprised you in a good way? And what do you think is problematic that our communicators and marketers might need to be prepared for?
What have I seen in a good way? Well, what I've seen in a good way is a recognition internally of how hard this will be, a recognition of the fact that it's not going to be as simple as just saying we're open and calling up patients and they're all going to come back. There's a recognition of the fear that we've seen in our research of consumers to come back to the hospital, need to overcome that. The other thing I've seen that's good that we've seen across the industry, but also with clients, is the increased use of virtual visits and telehealth to help facilitate all this. So all that's good. The bad thing, the worst thing is it kind of comes from what I just said. The way to do this is from a centralized, orchestrated approach. Come up with a plan that takes into consideration everything: organizational health, service line profitability, patient acuity, operational readiness. All of that needs to be done from kind of a centralized place and then rolled out as appropriate. This is from a marketing communication standpoint, right? But that's not what's happening. What's happening is chaos. What's happening is, because that's a new thing, particularly patient retention is a new thing. I think that's part of the reason why we're seeing this. Basically, you have all of the different places in the organization, physicians, physician groups, service line leaders, you name it, who are driving it individually.
Right.
Because they own, in the past, they've owned that communication stream. The kind of like, hey, if you're ready for surgery, we'll schedule you. There's patient education. That's all that happens at a clinical level. So now I think they assume that they're the ones that should be running it again in terms of patient retention. And so they're not thinking to include marketing. Marketing is looking at that nightmare going, can we even get in there and help them? The cat's out of the bag. They're already doing stuff. And so basically, instead of trying to approach this from a smart, orchestrated way, most health systems are just willy-nilly. That's the best way to do it. And I just, maybe that's the way it has to be, because it's a crisis and we can't get there. But boy, you would like folks to just say, look, we need to take at least a day or two to figure out the best way to do this. So we're consistent, so that we're clear, so that we don't confuse people any more than they already are. And I fear that's what's going to happen if those steps aren't taken.
I fear the confusion. I also fear people might get a little overconfident if the reopening in the first couple of weeks looks like, hey, everyone's coming back. I don't think you'll feel the marketing effect or lack thereof for a few weeks, maybe a month or two. But if you're not doing that stuff now, you'll definitely be feeling it in a month and a half. And you shouldn't get too overconfident just because the first week or two you're full.
Well, and there are definitely systems that are their census is full, and it's not just from COVID,
right.
or not COVID at all, to a small degree. But yeah, it's just, you need to really try to, to me, it's like, imagine opening a hospital health system from scratch, from the start. Would you just let all this happen organically? Or would you have a master plan of how you would go out to market and how you would communicate with your customers? The answer is obvious. The challenge, though, is what you've already brought up, Jeff. It's already a chaotic situation where we don't have the resources we need. We're being pulled still from COVID in other directions. So I know that makes it sound easier than it really is, but
yeah,
that's the utopia we at least want to strive for anyway.
All right. Let's go to, kind of talked about this a little bit, but how do you think COVID-19 will fundamentally change how health systems market once the crisis is over or we hit a smaller wave?
Yeah, so let's assume this is scenario one of the three from that article, right? So it pops up. It never goes away, but it just pops up here and there, but it's managed, as opposed to, an ongoing crisis or repeated waves like we're dealing with now. That's the $100 question, obviously, coming out of all this. The way I usually preface this when people ask me is, it's too soon to know for sure. So anybody telling you how it's going to be right now is, take it with every grain of salt, including what I'm about ready to say, right? Because again, we don't know where this is going to go. We're going to have to make some big assumptions to even make a statement like, we're going to come out of this, it's going to be okay. Any kind of thing in the fall will be minimal. Assuming those things, which are pretty big assumptions, I think there could be a dramatic change in how, like we said, hospitals and health systems are perceived in this country. And if that's true, forget about Joe Public doesn't care. Let's just say that people recognize the value, even beyond their own personal health care needs, which again are usually infrequent in a non-pandemic situation. And they see hospitals and health systems and physicians and nurses as we saw firefighters coming out of 9/11. Not that anybody ever had negative thoughts about firefighters before that, but we saw, like, they're just heroic. There's statues for them. If you go to the World Trade Center Museum, which I went to within the last year, there's just all kinds of dedications to the firehouses in New York City and stuff. And not to say the police weren't important and others, but those folks came out of that as like the depiction of heroism. If we see that, I think a lot of the things we typically deal with could be de-emphasized. So we've talked about cost, the fact that hospitals and health systems can be expensive. Now we're seeing why they're expensive. Now we're seeing maybe we should be funding them even better than we were before. So that's an example. I think the perception that somebody else is going to come in from outside and disrupt, I say it with such negativity, because we were talking about that before, and I think it's still fair, whether it's what's the name of the Amazon, I always forget.
Amazon, Berkshire Hathaway, JP Morgan.
Yeah, they got a name for it. There's a brand name for it. Look it
Is
up.
it Haven? Is it Haven?
Maybe Haven. Yeah, I don't know why I can't remember it. Haven or CVS. The real disruptor is United Healthcare, and they will still continue to disrupt. But the idea that like CVS is going to replace your local hospital or health system seems kind of almost silly now, right? Like your strep throat tests and your flu shots are very cute, but when somebody needs serious health, they're not going to you, right? And so I'm not saying that those things won't have an impact on our industry. Of course they will. But again, if we shift the lens of how we value hospitals and health systems and don't take for granted that side of it, then it shifts that conversation.
Well, maybe we get a little bit of a reprieve, but it's still up to hospitals and health systems to make the case and to sustain the case, right?
Yes, that's for sure.
Okay, so if today is May 4th, may the 4th be with you if you're a Star Wars fan out there.
Nice.
But if it's May 4th, if we fast forward a year and health plans are still pulling in mega profits like they are right now and projected to, and you are still not getting your rate increases and people have forgotten about you, and the media articles are back to CVS or back to the cost of a hip replacement or talking about charge master, then I think hospitals and health systems have not done their job to really fight for themselves.
Yeah, that's right. That time though is a long way away. I mean, if we come out of this, remember the assumptions we made were pretty like super positive assumptions. So let's just stick with those. We're going to have all kinds of conversations and investigations and discussions in the media at least a year. Remember, we got an election too. So all of this is going to be tied to politics going forward. The soonest that would happen, Jeff, I think would be a year from now, more than a year from now, probably later 2021. And that again assumes that everything goes back to a normal state of affairs with COVID. If COVID continues to be like life-threatening in the way it is now, whether it's a big giant wave again in the fall, or whether it's the ongoing crisis, the two scenarios from that article, 2 of the 3, it'll continue.
It'll continue, but the media will turn attention to something else. The public will, and
I don't know.
I just think that the hospitals and health systems, they've got to make sure their public relations and public affairs teams are stacked and ready and keeping their view at the forefront and staying on top of this. Most hospitals and health systems, they're not resourced well there. They have to spend a lot of their time dealing with crisis or putting out something positive in the news rather than this middle ground, which is advocating for themselves in a different way. Yeah. And I think that's something that if I was a health system right now, I would put somebody on that for the next 3 years, and that's their only job.
Yeah, and we would hope that the associations like AHA that have played that role will step up and play that role, continue to play that role. But we know that we're up against like an insurance industry that's done a better job of collectively painting a picture of, hey, we're the good guys. We're trying to retain costs, which that's a whole other podcast conversation we can have.
It's a whole nother podcast. Okay, we're at 2 minutes.
How many questions do we get there? Like 4?
Only like 3.
I think there's a really important one at the end that you wanted to get to.
There is. 3. Was it 3, Jaleesa?
Yeah.
Okay, so this is for fun. When does Iowa State bring back Fred Hoiberg?
All right, so you better get perspective on that, right?
Fred Hoiberg.
So let me. So first of all, it's okay to have some fun, even though we're in a pandemic. Jeff and I are going to talk to the thing that we love maybe most. It's hoops. So I grew up in Ames, Iowa. I'm an Iowa State alum. My family was actually family friends with the Hoibergs, so I have a personal connection. And of course, Fred Hoiberg is the mayor. He's the guy. That's what his nickname was, the mayor. He played at Iowa State. He was incredibly good. He played in the NBA, played for the Timberwolves, where I live now.
Do you play for the Bucks and the Pacers too?
He shot 48% from 3-point land for a season for the Timberwolves.
Is that true?
That's true. Look it up, man. He led the NBA. So anyway, he coached Iowa State and got them to great heights in the NCAA, and then pursued his dream job, which was with the Bulls. And that didn't work out so well. Now he's the coach at Nebraska. So I have to say, even though I'm a faithful Iowa State alum and I love Fred Hoiberg, he'll probably stay there because he has family roots in Nebraska. His grandfather, I think, coached there. So it's not like this is just some rando university he's at. He's just waiting for his opportunity to come back home. In some ways, this is home. So I don't know that he's ever coming back, Jeff. That's my in-depth.
That's your in-depth answer to Fred Hoiberg.
In-depth answer. Do you have anything to add for that?
I think I used Fred Hoiberg back in the day playing NBA Live on Nintendo or something like that. That's what I remember.
There's a question that just came in. Should we try to answer it, though? I can't see it.
Yeah, let's do it.
I can't see the whole question, though.
I see it. Not sure this is politically correct to throw out there, but hospitals in the big city have seen more COVID cases than those of us in the suburbs. Are we the safer option now? So the question for everybody, because I was stuttering, are hospitals in the suburbs that have had less COVID cases safer than those in the city now?
It's not even, I mean, it's not just the suburbs. There's also less populated areas, though obviously that's a different story if you have to drive 4 hours. So are we safer option now? Probably, though what I would say is most of the hospitals in big cities have taken all precautionary steps to make their facilities safer too. So I would say the facts are both should be equally safe. It's more the perception.
Right. That's
because
probably where she's coming from.
Yeah, if you're a hospital in a big city and you've taken on hundreds, if not thousands of COVID cases, people are going to fear coming to you. But I'm not going to go out there and say they're less safe than a suburban hospital, because from what I've seen, they are as safe. So it is more the perception that that's the case. Our research has shown, right, Jeff, that people don't even make a distinction between hospitals and outpatient surgery centers. Right. That they're equally scared of both. So
I think, though, if you're a suburb and you've already maybe tried that route of it's easier to come to this hospital than others, parking's easier, less people, less congestion, those things will still be a strength of yours, and maybe even more so now because of the perception. Anybody who was on the fence on that before might lean your way.
Yeah. Yeah, so it's tough crowds. Though. I mean, part of what I'm trying to balance here is I don't know that we would advocate that suburban hospitals pit themselves against city hospitals. I mean, we don't, that's the last thing we need right now. But I mean, if we're working with a suburban hospital, that's our job, and we're trying to compete against the city hospital. I don't know that we would advocate that you explicitly say, hey, we're safer than the city hospital, because I don't know that that's going to be true. So you can speak to all the positives in the way that you can. I just wouldn't explicitly call that out, because I don't know that you can defend that.
But implicitly, you may say capacity, that kind of thing.
Yeah, but you just got to be careful. I think you got to be careful with it.
Okay. Well, we are 3 minutes over. I still want to go one more basketball question. So if you're listening, you can stay on.
You're a basketball fan.
Stay on. The Last Dance on ESPN. 6 episodes so far. Michael Jordan's last season. What's your take so far? Have you watched all 6, Chris?
No, I didn't. I haven't seen last night's, but I've watched with rapt attention the first 4.
Okay, what did you think?
I love it. I'm just eating it up, and my wife is watching it with me. She's not a basketball fan. She knows Michael Jordan. She's a fan, and so she's asking me all these questions, and I just like revel. I'm like, oh, 1982. This is where Michael Jordan hits a winning shot from the left wing. She's like, what are you talking about? I'm like, oh yeah, that game ended when the Georgetown player threw it to the other team. She's like, how do you? I'm like, I don't know. I was 14 or 15, so I saw his whole career. I love it. I don't know about you.
I've loved it too. I'm a little younger, so I definitely followed Michael Jordan. But remember, for those of you out there, we we didn't have social media. Every game wasn't on TV every night. So I had to read box scores and things like that. And I never really went back and watched his career closely as I got older. So this has been really, really nice for me to see. I think they're doing a great job going to the last season, but then going back in time and going back and forth. I also have my daughter watching it with me, who's not really even a basketball fan, but she was kind of drawn to the story and how competitive he is. And so she's been watching, and the last 2 episodes have been really good. Enjoy it.
Julissa, are you watching?
I am not not consecutively, but I've been watching it. Yeah, my husband's been all into it. So kind of for the same reason. I'm a soccer person, and so basketball has never really been something I've followed. But I mean, it's an amazing story, so it's good.
I would say I venture to guess it makes a difference if you were there for all of it, because it's as much nostalgia for me as anything.
Mm-hmm.
The debate between him and LeBron is ridiculous. Like if you saw him play, you saw Michael Jordan play, it's not a debate. I mean, I think LeBron's incredible, but it's not. He's not better than Michael Jordan. And my favorite story is my oldest was born in February 1998. And there were 2 times when I was holding him as a baby where I freaked him out because I yelled. One was when Mark McGuire passed Roger Maris for the home run record that summer, which of course now is probably a spoiled record. But I'm a Cardinal fan, so it's huge. But the other was when Michael Jordan hit the shot over Byron Russell. Byron Russell? Is that right?
Brian.
For the Jazz, which is going to be spoiler alert, but obviously this is history. I'm sure in the finale of this show, and I was holding him and I just yelled and he woke up, and I still remember it vividly watching that. It was incredible.
He's incredible. I remember debating with somebody about a Laker fan about Jordan versus Kobe, and Kobe's amazing player, so good, but you go back and look at the stats, and Jordan would average 35 points a season and shoot over 50% every single season.
He just, if he hadn't left, I wonder if the show will get into that. They might have won 8 in a row.
Yeah. The show's not going to get into too many bad things.
No, because
he has approval of it all.
Yeah, his production company's behind it. I don't know how they don't address him leaving though.
I think they will in episode 7. 5 and 6 is getting close.
All
right. Well, hey, everybody who stayed on, maybe we should have a basketball podcast. Yeah. Basketball podcast coming up next. Anyway, that's it for today's show. Chris, thanks for joining as a guest.
Oh, I loved it. Thanks for having me.
Yeah.
Julissa, thank you very much.
Yeah, no problem.
Tomorrow, Chris will be back as the host and be joined by Reagan McFarland from ReviveHealth, talking about how marketers are leveraging video and content creation during COVID-19 crisis. Reagan, looking forward to that conversation. Remember to visit www.thinkrevivehealth.com/COVID-19 for today's episode and all the other things we've got out there. Really good resources for everybody. You can also subscribe on iTunes and let others know about the podcast. So thanks everyone for all your amazing work out there. More important than ever, bringing the critical skills you have to your organizations and to your communities and to everybody you work with. We'll be back tomorrow and every weekday until all this passes. Talk to you then.
Bye. Bye.